I think as a retina specialist, all of us would agree that our load of diabetic patients over the years is going exponentially high, and in my personal experience in our OR, while 10 years back, the number of diabetic cases were say around 10 to 20%, and now it is reaching up almost up to 50%. So the number of cases of diabetic retinopathy and its complication have gone high significantly in past decade or so. So why diabetes mellitus? I have chosen this topic because diabetes mellitus has reached epidemic proportions worldwide. It affects almost 4% of the world's population, and at least 170 million people worldwide have diabetes. And this figure is likely to double by the year 2030 to around 400 million. In India itself, the diabetes has attained epidemic proportions, and the numbers have increased from approximately 2.6 crores in 2000 to approximately 4.6 crores in 2015. And we are having very rapid rise in the number of patients. And once you have diabetes mellitus, diabetic retinopathy is bound to occur in both type 1 as well as type 2 diabetics. All of type 1 and most of type 2 diabetics will develop diabetic retinopathy after 15 years of having diabetes. And we know that diabetic retinopathy is responsible for approximately 5% of the blindness, which constitutes around 40 million cases overall throughout the world. Half of all diabetics would have some degree of diabetic retinopathy at any given time. Now, irony is that most of this morbidity is largely preventable and treatable, especially if we pick up these patients timely and intervene appropriately. And even WHO has recognized that diabetic retinopathy is fast becoming an important cause of visual disability. So I'll be highlighting certain key factors in the diabetic retinopathy under these headings. First, coming to the epidemiology, I've already highlighted the fact that diabetic retinopathy is the leading cause of new cases of blindness in people aged 20 to 75 years. It has considerable impact on both the patients and the society because it typically affects individuals in their most productive years. And prevalence of minimum diabetic retinopathy approaches almost 100% after 20 years of diabetes. Now, these are the certain key factors which have been highlighted again and again over the years by almost every literature on diabetic retinopathy. And we know that duration of diabetes and glycemic control constitute the most important risk factor for diabetic retinopathy. Nephropathy and uncontrolled hypertension remain factors which lead to augmentation of existing diabetic retinopathy. Any factor which reduces the blood carrying capacity of the blood would further worsen the diabetic retinopathy, and these would include decreased hemoglobin, smoking, hyperlipidemia, carotid artery occlusive disease, which decreases the blood flow to the eye, further worsens the diabetic retinopathy. And we all know that pregnancy is a risk factor to already existing diabetic retinopathy. Some of the ocular features which are less frequently talked about is PVD. Now, vitreous plays a very important factor in the causation of diabetic retinopathy, especially the advanced forms of diabetic retinopathy leading to TRD and subsequent loss of vision. Now, one must remember that if there is PVD, it reduces the chances of advanced forms of diabetic retinopathy. But in our experience, we have all experienced that total PVD is very rarely present in patients with diabetes. Patients with degenerative disorders, for example, retinal dystrophies, patients with high myopia, because the demand of the retina is lesser, so these patients tend to have lesser diabetic retinopathy. And very often we have patients which are unilateral myopes, and they tend to have less severe diabetic retinopathy in the eye with high myopia. Cataract surgery, again, we know that it augments or it worsens the diabetic retinopathy. And any form of diabetic retinopathy, especially diabetic macular edema, should be treated before we go ahead with cataract surgery, or for that matter, any intraocular surgery. I'll just rush through these slides because we're all aware about how to identify diabetic retinopathy and how to stage it. But we must remember some of the red flag signs, which include venous bleedings or irmas, which when present indicate that we are moving towards the severer forms of diabetic retinopathy. And these patients would require more close follow-ups and regular checkup of the fundus. Once we have neovascularization of the retina, which may be present at the disc or around on the disc at the posterior pole or in the periphery, these patients become candidates for diagnosis of proliferative diabetic retinopathy. And we know that these patients are at very high risk of developing vitreous hemorrhages, subhyaloid hemorrhages, and subsequent tractional retinal detachment and combined retinal detachment, which can absolutely reduce the chances of any visual gain subsequently. So I'll just show you, I think all of us are aware about microaneurysms are very commonly seen and maybe the first sign of diabetic retinopathy. And remember, whatever we see on color fundus photographs or clinically, much more microaneurysms are usually seen on fluorescein angiograms, and we must not be alarmed to see so many of them which are not actually visible on color photographs. As I already mentioned, these are some of the red flag signs. Once you start seeing venous bleedings, irmas, or even cotton wool spots, these are indications of severer forms of diabetic retinopathy, and these patients require closer follow-up. So all these features, fortunately, are very easily visible on color fundus photographs, or for that matter, even on clinical examination. And once we see these may be an indication of taking the patients up for further angiography, which may be in the form of a non-invasive OCTA, or it may be in the form of conventional fluorescein angiography. Sometimes these patients can present to us where there are somewhere midway between severe NPDR and mild NPDR, and we label these patients as moderate NPDR. So subsequently, these patients go on to develop neovascularization elsewhere or on the optic disc and became candidate for diagnosis of proliferative diabetic retinopathy. Now, diabetic maculopathy, I'll not be talking because there is a separate talk on diabetic maculopathy, so I'll skip this part. Fluorescein angiography has been present for decades. The role of FFA is decreasing as we are moving towards the OCTA, but we must remember that it still remains a very useful tool for the neovascularization, which is not visible clinically, and it is also a very valuable tool for detection of ischemic maculopathy. OCT has almost become irreplaceable for the diagnosis and treatment and subsequent follow-up patients with diabetic macular edema, and it's almost indispensable for the detection of tractional macular edema, for which surgical treatment remains the diagnosis of choice. Now, these are some of the clinical scenarios which we must be aware about. Sometimes you will come across these patients where the diabetic retinopathy is asymmetrical, and we must not get confused once we get across these patients. Remember, there are several reasons why a patient can have diabetic retinopathy, which could be ocular or systemic. Some of the common systemic factors which can lead to asymmetric diabetic retinopathy include carotid ischemia, a unilateral carotid disease, or ocular disease, something like degenerative disorders, which can lead to asymmetric diabetic retinopathy. Or, for example, this patient where the patient has a AIN in the left eye, where because of the optic atrophy, the disease is less severe in the affected eye, while the other eye has more severe disease. A condition like this, now, if you look casually, this patient would seem like diabetic retinopathy, where there is diabetic, where there is a neovascularization at the disc, neovascularization in the periphery. But if you carefully look at this patient, the posterior pole is virtually normal, and most of the changes are in the periphery. There are microaneurysms in the periphery and peripheral knockdown of the vasculature, which indicates that this patient is actually a patient of ocular ischemic syndrome, and we are not dealing with diabetic retinopathy here. Which is again not a common thing is radiation retinopathy, but once in a while we do encounter these patients, especially with increasing use of brachytherapy. So we must not forget that this is an entity which can commonly imitate diabetic retinopathy, and we should always be immaculate in our history taking. Sometimes patients with bilateral severe disease like this can be confused to have CRVO or bilateral hypertensive retinopathy. But remember, we very commonly see nowadays patients, especially because of loss of follow-up because of the COVID situation, patients do come up with severe disease like this at times. So over a period of time, these patients go on to develop vitreous hemorrhages, which can be subhyaloid or diffuse hemorrhages. These patients go on to develop tractional retinal detachment and subsequent neovascularization of the iris. But much less commonly talked about is this scenario where the patients develop generalized and more diffuse areas of capillary non-perfusions. The patients, the fundi look almost normal, but once we go on to do angiography of these patients, we find that these patients have very extensive knockdown of the retinal vasculature, and the patients have severely reduced decrease of vision. Not very commonly we come across these conditions where the foveal exudates migrate beneath the fovea and lead to severe decrease of vision, which is almost non-treatable. So there's basically this list of common causes which can lead to severe reduced vision in these patients. I've already explained in detail. Now, fortunate thing is that most of these complications can be easily avoided if we detect the diabetic retinopathy in time and we institute appropriate in treatment at an appropriate time. And this is general guidelines. We must spread awareness to all treating diabetologists that the patients must undergo regular screening for diabetic retinopathy, especially if the patients have any diminution of visual acuity, any decrease in the contrast, any floaters, or any painful eye. These are few of the indications when a diabetologist must refer the patients to a general ophthalmologist or retina specialist. Coming to management, I think always very commonly it has been highlighted about the eye treatment, that the patient should undergo anti-VEGF injections, the patient should undergo laser. But before we take on the eye treatment, these are the factors which must be which we must take into account. The patient must undergo a thorough systemic screen, and we must ensure that patient is under good glycemic and hypertension control. Some of the factors, for example, hemoglobin. This is a paper published by PGI team long ago, and they have shown that just by managing the hemoglobin of the patient, the diabetic retinopathy tends to reduce over a period of time. Similar is the effect by the stoppage of smoking. And of course, if these patients are on statins, they also help in reducing the severity of diabetic retinopathy. All patients with diabetic retinopathy, with or without diabetic retinopathy, must undergo regular follow-up. Once the patients have any amount of diabetic retinopathy, the duration of the follow-up, duration between the follow-ups keeps on going down as we move towards the higher grades of diabetic retinopathy. I'll not be talking about diabetic macular edema because there is separate talk about it. But remember, for diabetic retinopathy, proliferative diabetic retinopathy, pen retinal photocoagulation remains the gold standard still, because it gives us a finite treatment end to the treatment. There has been talk about anti-VEGF monotherapy, but remember, it does not work well in long term, especially in our scenario, because patient tends to lose to follow-up. And one of my suggestions to all general ophthalmologists is, please do not inject patients with the anti-VEGF if they have evidence of fibrovascular proliferation. Most of these patients, once they are treated well in time with pen-retinal photocoagulation, they tend to retain good visual acuity until the last. So when do you refer the patient to vitreoretinal specialist? So any of the indications of vitreoretinal surgery, which include recurrent or persistent vitreous hemorrhage, tractional retinal detachment, which is involving or threatening the fovea, a secondary regmatogenous RD or combined RD. These are the few of the indications when the patients would need surgery and should be referred to a vitreoretinal surgeon. Relatively rare indications include thick taut posterior hyaloid and diabetic macular edema with vitreous traction. One last but not the least, when you find that vision is not commensurate with ocular finding, these are the patients which should be referred to a vitreoretinal specialist. To summarize my talk, I wanted to highlight that diabetic retinopathy is a very common entity nowadays in our clinics. It is potentially blinding, but the blindness due to diabetic retinopathy can be easily avoided by early detection and appropriate treatment. Lifelong regular follow-up of these patients is must, and we must not forget that the underlying cause of all this diabetic retinopathy is poor systemic control, and we as vitreoretinal specialists as well as general ophthalmologists should highlight the role of good metabolic control at each and every follow-up. Thank you.